everyone. In this episode, I interview Dr. Paula Briggs about the menopause. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into my podcast. In this episode, I'm going to interview Dr. Paula Briggs about the menopause. Paula is a consultant in sexual and reproductive health and is also the current chair of the British Menopause Society. This makes her well placed to discuss with us and educate us around all things menopause. I'm delighted to have her on the show. Paula, welcome. Thank you so much for joining me today.
Thank you, Gail.
So, Paula, I find it really fascinating to learn why high-flying colleagues like yourself choose various areas in medicine in which to practice. So, can you let us know why you opted to have an interest and focus on the area of the menopause?
So I'd say that my interest in women's health developed over time. I started off my career as a GP, and I was a GP for nearly 20 years. And during that time, we set up an independent sexual health service. And I then became part of an acute trust with gynecologists, set up a community gynecology service. And menopause was a very big part of that service. Heavy periods and menopause were probably the two most common referral areas. So it's been a gradual thing. I think it's very difficult to identify why you would choose something, but menopause has become the focus of lots of women's attention for a variety of reasons, and I think some of that is due to the input of celebrities and politicians, and awareness raising is great, and I just think it's really important that we try to normalise what is basically a life stage and not a medical condition and not a deficiency state. So I'm really keen that women are provided with the right information on which to base their choices about how they manage this life stage, and that nobody should feel, one, that they can't get HRT if that's what they want, but also that they should not feel that they have to have HRT if they don't want it or it's not appropriate based on their medical history.
Perfect, great answer. So that really chimes with the whole ethos of this podcast. It is to inform patients, to educate patients so they can make appropriate decisions for themselves. So as you know, it is aimed at educating patients, the podcast, and for that reason we try to avoid using medical terminology as far as possible so that it remains as accessible to as many people as possible. Okay. So let's start with the basics. What exactly are the menopause and the perimenopause?
Menopause really is a stage in women's lives when their ovaries stop producing eggs. The perimenopause is the run-up to that stage in life. So you've got reproductive life when you're capable of having children, and then post-reproductive life when the ovaries are no longer producing eggs. But the transition period, the perimenopause, is the time when women's hormones are most variable and the time during which many women will suffer the most severe symptoms. And sometimes it creeps up without them becoming aware that it's happening. So they may still be having regular periods and therefore they don't think, could this be menopause? But they might be suffering from anxiety or difficulty sleeping. So that's the reason for having the information up front. And I do think that post-menopause is much easier to define. That's 12 months after a woman has her last period.
Okay. And you started to mention some of the symptoms. But can you give us a whistle-stop tour of the symptoms that may help recognize the menopause or the perimenopausal period and may make women think, oh, well, maybe this is a perimenopause. What are the common symptoms?
One of the commonest symptoms actually is a change in bleeding pattern. Periods might become heavier or the gap between periods shorter or longer. And that's quite an unrecognised thing. Then you've got the classical symptoms: hot flushes, night sweats, difficulty sleeping, fatigue because you don't sleep. And I think that tips over into things like brain fog, difficulty coping, for example, at work. And low mood is also quite a common symptom, and that's difficult sometimes to differentiate from depression. And I think because historically women were offered antidepressants instead of HRT after there was a big study called the Women's Health Initiative study in 2002, there is often a reluctance for women to accept antidepressants, but sometimes they need hormone replacement therapy and antidepressants. So I think one of my messages is about getting the right information to women, and also having an open mind about different treatments. Sometimes we add things together. And then things that are less frequently talked about are symptoms of lack of estrogen on tissue quality in the vagina, the vulva, which is the outside, the bladder, and the urethra, which takes the urine from the bladder to the outside. And lots of women will get symptoms associated with that condition, which has got various different names, but urogenital atrophy is a name that describes what's going on. Those symptoms don't start until about 3 years after the last menstrual period, so they're less easily associated with menopause, but very common and very, very treatable. And then, I kind of divide things into acute, intermediate, and long term. These are not symptoms in the long term, but lack of estrogen can affect bone mineral density, and it can also affect cardiovascular health. But whether you have HRT for those symptoms, that wouldn't be the recommended reason for having HRT to prevent osteoporosis or cardiovascular disease. And it's so important that women have a health assessment. So they should be able to see, it could be the GP or it could be the practice nurse, to have a blood pressure checked, a body mass index measurement, review of their medication, and just a chance to discuss things with somebody who's got a reasonable level of knowledge. And I think you've obviously provided me with some insight into what questions you were going to ask, but that's the difficulty, that knowing whether the person you're seeing has got the appropriate expertise. And I think, there are some outstanding GPs, amazing GPs, super qualified, but it's very difficult. It's very mixed, and general practice is a very difficult job. You have to be good at everything, and obviously that's not possible. So I suppose in any one group of practices, it would be nice to identify the person who's got an interest not just in menopause, but in women's health generally.
Yeah. And does everyone have these symptoms to varying degrees, or do some women don't have them? And
yeah.
Is it highly variable from woman to woman?
Very variable. And I think most women will get some symptoms, but most women would cope with the symptoms they get. However, there are women that are extremely severely impacted by the symptoms. And that's what's really important. If you're experiencing the odd hot flush but functioning, for example, at work without any difficulty, then you have maybe more options. There isn't it's not absolutely necessary to have HRT if you're relatively asymptomatic. But, for some women, the symptoms are severe and long lasting, because women will often come and say, how long is this going to last for? And it's really difficult to predict. What I think we are seeing now, due to awareness raising, is women who have kind of missed what we call a window of opportunity for cardiovascular benefits, asking about starting HRT, for example, in their 60s and 70s. And that's a much more difficult decision, because as you get older, you develop more other medical problems. You might become hypertensive, so have high blood pressure. You might have type 2 diabetes, high cholesterol, underactive thyroid. All of those things are more likely as you get older, and it's more complicated then. And the other thing that we're seeing now is women who are younger asking for treatment, and it's more complicated in those younger women. So if the woman is below the age of 40, we do blood tests. And if these blood tests are normal, then you can't make a diagnosis of premature failure of the ovaries. The most difficult group, I think, are women between the ages of 40 and 45. That's very difficult, because the blood tests are often normal, but it doesn't mean they're not experiencing symptoms associated with changing ovarian function. However, if there's no risk factors in those women, I think we can manage them with combined hormonal contraception, with pills containing natural estrogen, just like HRT. And there are two. There's a pill called Zoli and a pill called Clara. So I don't think we have to necessarily give these women HRT as long as they're eligible for contraception. And that's important because actually they're still at risk of pregnancy. And we see women in their 40s presenting with an unplanned pregnancy, and they're more shocked than any other age group because it's just not on their radar. I think women think when they start having menopausal symptoms that that's the end of their reproductive life, but you get the odd ovulation, and that can lead to pregnancy. So again, that's another really important message, that women should not forget about contraception. They are still potentially fertile even up to the age of 55.
Okay. And so the symptoms can vary widely from patient to patient. I always ask about things like risk factors, lifestyle factors. Are there any factors that may affect how severe the symptoms are or delay symptoms? Is there anything that women can perhaps do to make them less likely to have more severe symptoms, or is it genetic? Any ideas, any thoughts about that, or do we not know?
I think that's happening just now is women are terrified of what's going to happen when they become menopausal, and we don't know. There is no way to predict how severe somebody's going to experience their menopause. But I think in general, it's a really good time in your life just to be able to reevaluate your health. So it's really difficult, isn't it? Everyone's busy. I think we do less cooking from scratch, which would be better for us. It's more difficult to fit in exercise, but even walking half an hour a day, 5 days a week really makes a big difference, and not buying sort of processed food makes a big difference. So I think it's a real investment in time, and I don't think it's appropriate to put women on HRT who've got high blood pressure. I would say get your blood pressure treated and then have HRT. But lots of times women, as they lose weight with more exercise and a change in diet, will actually feel better. I mean, not everyone, but I think lifestyle changes are a really important part of managing this life stage. Some women like to do cold water swimming, wouldn't be me, but it can have a really positive effect on mood. So I think it's just investing some time for yourself, and it's a hard time in life anyway. So you're possibly dealing with children leaving home, elderly parents. You might be in a full-time job. We've just had COVID, so I think people need to be kind to themselves as well. But HRT on its own is not going to fix all of those things, and I think it's really important to set expectations at that level. So it's a part of how you might manage the life stage, not the answer to everything. I think what I'm seeing, and this is just anecdotally, going to the hairdresser, she said to me, I haven't felt well this week, so I've doubled my HRT. And I was just like, well, you wouldn't do that with any other medication. And it's just like, well, then she said, oh, you're right. And I think people are getting a bit carried away, which is understandable, because every time you put the television on, it's something about menopause. And I think it's great that there'll be a focus on how we support women in the workplace, but we need to support all women. And there will be women who are working with, say, rheumatoid arthritis or Crohn's disease and diabetes, and everybody should have the same opportunities to manage their symptoms, whatever is the cause of those symptoms in the workplace.
Okay, that's a brilliant answer, very comprehensive. Thank you very much. And so let's talk a little bit more about HRT in greater detail. What are the benefits and what are the risks?
There's no doubt that for classical menopausal symptoms like hot flushes, night sweats, difficulty sleeping, replacing estrogen is the best way of managing those symptoms. And if you give a woman who's still got a womb estrogen, then you need to give her a progestogen to keep the lining of the womb thin. And if you don't do that, then the lining can become too thick, and that's a risk factor for endometrial cancer. So it's important, if women are going to use estrogen, that they use sufficient amounts of progestogen, and that could be with Mirena, which is a coil fitted inside the womb with a hormone in it, or it might be a capsule called Utrogestan. or it might be a combination product. And for some women who would struggle to remember the capsule, say, having everything in one patch. Now that would be me. I would forget the capsule because you take it at night time and it's the kind of last thing on your mind. Well, I'm talking about myself now, but I think what you recommend for an individual woman depends on what she would like and what she's likely to be able to cope with.
Okay. And any other benefits besides treatment of hot flushes and night sweats and sleep, etc.?
So I think with mood-related symptoms, as I said before, it's much more difficult to predict the outcome. Because menopause has kind of exploded and there are lots of providers, and I'm not sort of criticising anybody's particular practice, but I personally feel that we should stick with guidelines. So when you have medication that becomes licensed as a result of a drug trial, the drug becomes licensed at the dose that it was trialed at. So for example, with patches, the top dose is 100 micrograms. With gel, it's 4 pumps if we're talking about Oestrogen, which is one option, or 1 milligram of Sandrina. So I've seen women now who are on, say, a mixture of things. They might be on a patch, a gel, a pill. And that's really difficult because if something happens to that woman, she gets endometrial hyperplasia or cancer, what was the cause of it? Now, it could be her inherent risk factors because there are lots of things that increase the risk of endometrial cancer, and being overweight is a significant risk factor. But if we give higher doses than are licensed of estrogen, irrespective of what that woman's blood test is showing, then I think we potentially increase her risk. And there are some fantastic guidelines which have been produced by the British Menopause Society, so practice standards to support GPs. And I don't know, did I share with you the patient booklet that I had done? No, so it's a really comprehensive patient booklet which has got peer-reviewed information. And I actually did that with a breast surgeon because the breast cancer area is the most complicated. And I think it's really important to bring in other specialists. So we're just in the process of doing a very similar booklet for women who've got gynecological cancers, because these women are more complicated and I think they should be managed in multidisciplinary teams. So those are the women that should be coming to our secondary care menopause services. The premature ovarian failure as well, because they may be eligible for treatment with egg donation if they haven't had children. So we should probably be seeing 10% of complex women delivering education, doing research, and most menopause management should be done in a primary care setting by GPs, nurses, pharmacists, but they need a lot of support. And I think that's again where I see my role as a mentor and supporting them. So, you know, they contact, certainly in Liverpool, I get contacted a lot about, is this the right thing to do? Or today it was Utrogestan isn't available. So it is actually, there was a problem with a stock delivery, not the actual production of that capsule. And I think communicating with other clinicians is incredibly useful when we think about patient care.
Okay. And you, in speaking about the benefits, you have mentioned a couple of risks. So you mentioned the risk of breast cancer, and as you know, I'm a gynecologist, and that maybe is probably the most concerning risk for women, breast cancer. Yeah. So can you talk a little bit about, kind of give us put it in perspective? Yeah. Okay. What is the risk like for breast cancer?
So to put it in perspective, there are other risk factors which are probably more significant. So again, weight is a risk factor, alcohol consumption, family history. The background rates for breast cancer are very high, and we think breast cancers take 20 plus years to develop. So HRT would be seen more as a promoter rather than a cause. But I think I always have that conversation with women before they start HRT, because if they've been developing a breast cancer for the last 15 years and I give them estrogen and it promotes development of the cancer and they present sooner, they're going to blame themselves for having had HRT. And it's not that. They present sooner and the end mortality is exactly the same. And it's not zero. I think it's being very much played down on social media. I've seen posts where people are saying it doesn't matter. Well, obviously it matters. Everything about your past medical history matters, and we would like to think that women get individualised care. That was one of the important messages which came out of the NICE guideline that was published in 2015. But for those women who either have a very strong family history or they might have a BRCA mutation, or they might have actually got breast cancer and be having treatment with drugs like tamoxifen or aromatase inhibitors, which get rid of all of their estrogen and who are extremely symptomatic. There are new drugs coming to market very soon called neuroendocrine antagonist drugs, which are licensed to manage hot flushes, night sweats, and some of them will improve sleep. So I think that women in that situation shouldn't take risks, because if they have a recurrence, it's going to be really difficult for them. Not to say that they won't have a recurrence, they might have, but as long as they haven't had medication which could contribute to that, I think that makes a difference. And just for anybody who's listening who has got breast cancer and who is on tamoxifen or drugs like aromatase inhibitors, letrozole is an example of an aromatase inhibitor. Oasis 4 is a clinical trial which is due to start in December, and we're recruiting to that trial. So they can contact our research unit, which is research@lwh.nhs.uk, if they want to take part in that study.
Okay, brilliant. So I'll put that address in with the notes of the podcast so that people can refer back to it.
And I'll also send you the link to the booklet, just in case people...
Yes, I was going to say also the link for the booklet. That'd be fantastic. Brilliant. And in terms of, so that's breast cancer. In terms of womb cancer?
Yeah, so there are specific risk factors for cancer of the womb, things like being overweight, not having children, polycystic ovarian syndrome. But as I said before, unopposed estrogen or minimal progestogen can increase risk, but it's probably quite complex. However, I think that's the reason why women take progestogens. It's not to control their symptoms, it's to make sure that the lining of the womb doesn't get too thick. But sometimes that gets lost in translation. And even women who've had a hysterectomy initially close to the surgery, if it's for endometriosis, we would normally recommend that they have a progestogen, or if they've had types of endometrial cancer where there could still be deposits of endometrial tissue, we sometimes recommend that they have the progestogen part as well. So it's not as clear as if you have a uterus, you have to have the progestogen, and if you don't, you don't need it. However, the other extreme end of that spectrum is we're seeing women now sort of 10 years from their hysterectomy for endometriosis suddenly being put on a progestogen, and that's not really all that logical. Unfortunately, there's really no clear guidance about how long that should happen for. And the number of women who would have endometrial tissue left behind will be small, but it's still there as a risk.
Okay, and I've got to put my gynae hat on to say, and if you have unscheduled bleeding on HRT, postmenopausal bleeding, please go along to your doctor to be investigated, because it is one of the cancers that can show up, give warning signs, give red flags quite early. I'd say
with the explosion in the number of women using HRT, we are also seeing a massive increase in the number of women presenting with abnormal bleeding. So they're then currently being investigated in a kind of rapid access service, which is for women with potential cancers. And that is very alarming, because you don't normally get into the hospital within 2 weeks and have all kinds of quite invasive investigations, transvaginal ultrasound scans. They might have a biopsy and a hysteroscopy. So that's another reason, I think, for just taking a step back and women really only having HRT if they need it for symptoms, or they've got an incredibly strong history of osteoporosis and they're not able to manage that with diet and exercise. But I think that gets forgotten when celebrities are asking why can't all women have HRT. They're not seeing the investigations that women are having because of the side effects of HRT. So it needs to be balanced, and it needs to be right for each woman.
Very sensible. Okay, and does it matter what type of HRT is used? So you mentioned before that there are various preparations, various ways of delivering HRT, tablets, patches, gels, sprays,
Mm-hmm.
etc. Does it make any difference? Does it matter, or is it just, are some better than others, or is it just kind of a lifestyle thing that you're going to forget your progestin, so you're better off with a patch?
Everybody is using transdermal products now. That's through the skin, and that might be a patch, it could be a gel, it could be a spray. Um, the thing with transdermal estrogen is it doesn't increase the risk of blood clots. Now, the patient may have their own risk. They might be overweight, they might smoke, they might have already had a blood clot. And in that situation, even if they're only sort of a little bit overweight, then it's probably a safer option. And we also know that micronized progesterone, which is in the little capsule, estrogen, is the safest when you look at the risk of breast cancer because it actually kind of bumps off abnormal cells. So that's a positive thing. However, for the vast majority of women who've got no contraindications to HRT, the differential between products is probably very small. And mentioning that study, the WHI study, that used a synthetic progestogen called medroxyprogesterone acetate, which is thought to have a higher risk. But I think the real risk is with the patient. So I think if we address the patient's risks, we've got more choices. And we had real issues with availability of estrogen because it was being used so much, which is good and bad. And I think I've mentioned already using doses outside of the license. That's another reason why I think we shouldn't do that. If you get to 4 pumps of estrogen and you're still symptomatic, then we need to think about another option.
Okay. And so you mentioned about patients with breast cancer, for example, and you mentioned about complex patients that should be seen in secondary or even tertiary care. So my next question is, can anyone have HRT? And are there any circumstances which you would say absolutely needs to be avoided?
Yeah, so I mean, everybody can't have HRT. That's another myth that's being propagated at the moment. I think it's often a really difficult decision in much older women. I've had older women come to see me, and at the end of the consultation, we've looked at the risks and benefits, and I might say, actually, I think your likely benefits are going to be outweighed by risks. And sometimes they're quite relieved. You know, they don't necessarily really want to have HRT. They just want somebody to explain where they are in their menopause journey or what potential benefits they might have. And there are always going to be bone benefits, and there's always going to be a beneficial effect associated with vaginal estrogen. Vaginal estrogen is appropriate for virtually everyone. Only women on aromatase inhibitors for breast cancer would it be controversial really to give somebody vaginal estrogen, and even in those women sometimes gynecologists might consider doing that alongside breast surgeons. But I think, you know, you get women who have had a cardiovascular event and they're not stable. That would be a really difficult decision, and you could increase the risk of a further cardiovascular event, which could be catastrophic, not necessarily terminal, but living with the after effects of a stroke. You know, that's really difficult if you've been previously fit and well. So I think there are the hormone dependent cancers, like you said. There's complex cardiovascular disease, and the POI patients who probably just need a bit more intensive support, who should be managed in secondary care.
Okay. And for these women, like those who you think, well, I think, because we always weigh, don't we, benefits versus risk. And in these women where risks, clearly it would appear, would outweigh benefits, are there any other options? Is there any other effective treatment that perhaps they can try to alleviate the symptoms?
There are other treatments, and I'll talk about that. But I think the problem when women have got other health issues is they often don't feel that well because of the other health issues. And I think it would be unfair to suggest that they are going to feel better, significantly better with HRT. So it's difficult, and it is all about expectation setting. So for For breast cancer patients where it's not thought to be safe to give hormones, we often use antidepressants, not for depression, but for the effect that they have on hot flushes and night sweats. So we frequently use either venlafaxine in a very low dose, or mirtazapine, which is another antidepressant, and in a very low dose, actually, it has a really beneficial effect on sleep. So again, it goes back to having an open mind and understanding that you're not being fobbed off with antidepressants, that there is a reason why they're being provided. We sometimes use oxybutynin, which is licensed to treat overactive bladder, so that's weeing all the time. It causes a dry mouth, but it will reduce hot flushes and night sweats. So it might be an option for some women. Clonidine is the only treatment which has a license to manage, the only non-hormonal prescribable treatment that has a license to manage hot flushes. I have probably seen that work in about 5 patients in my career over 30 years, and it's not my go-to. It's not a very nice drug. You have to gradually reduce it. It's an antihypertensive, actually, so when you stop it, the blood pressure can drop. So that wouldn't be my preference. My preference tends to be usually venlafaxine, or if sleep's a major issue, mirtazapine. And then, of course, there are drugs or medications that women can buy over the counter. These are herbal medicinal products, so they may have estrogenic effects. They've got plant-based estrogen in them. So that's tricky, because if the patient's got a contraindication to estrogen, you just have to be cautious about them buying stuff over the counter. And I'm not a fan of black cohosh. It was favourably reviewed in the NICE guideline, but it can be quite toxic, and it's really difficult when you're accessing medication from a health food shop, because the drugs there are unregulated. They haven't been subjected to the same standard of clinical trials as licensed medication. So I think I'm always more comfortable if, as a clinician, I'm prescribing medication, or I'm asking the GP to prescribe medication, than I am suggesting women access treatment via a health food shop, for example. But, there are things that help women, things like sage, flaxseed oil. It depends on the individual woman, and at the end of the day, I think women have to make their own choices about how they manage their menopause. But what they shouldn't be, I think, is excessively influenced by media pressure. What we've got now, to me, feels very similar to where we were in 2002, when the Women's Health Initiative study was initially leaked to the press and then obviously finally published. But things are a little bit unstable, because we've gone from being stable in just after 2015 to seeing like a rocketing in prescriptions. And there's a lot of criticism of GPs, but it was not a job that I would choose to have stayed in, because it was so difficult to do. So we're also seeing a lot of GPs leaving the NHS and setting up private clinics. And that, menopause is not a specialty. It's part of gynecology. And it's something that I truly believe should be delivered in an NHS general practice setting. So I think I'd be, if you're going to pay money to see a specialist, just be careful about where their specialist status comes from. We need to all be sure about what we're buying. I suppose it's the same as anything else.
Okay. And have you any views about other therapies? For example, acupuncture. Is there anything else? Because women come asking that, don't they?
Acupuncture cannot be subjected to a randomized controlled trial. So it's always going to be difficult to know whether it makes a difference, truly. If it makes the individual patient better, I haven't got a problem with it. But that would be one of the difficulties. And, testosterone prescribing has also gone through the roof. So looking at what available clinical trial data is there is also a huge placebo effect with testosterone, and it's being promoted as the missing link, the final piece in the jigsaw. But the reality is that female ovaries continue to produce testosterone even after the menopause, and women will often experience problems with sex drive because the relationship's not good, or they're exhausted, or they've got bad urogenital atrophy, and so they naturally don't feel like sex. So again, the expectation that having some testosterone is going to transform the way you feel is unrealistic. And at the moment, the only indication is for low sex drive. There is no other recommendation for things like aching joints, because people will come and ask for testosterone to improve energy levels. There's no evidence for that. And I think, just on the back of everything else I've said, I think we need to be very clear about why we give women medication that can potentially cause side effects. So if women use excessive amounts of testosterone, they could have irreversible voice changes, male pattern baldness, they might get clitoromegaly. I mean, all of these things are unpleasant. So the recommended amount for women is 50 milligrams over 10 days, and we have no licensed product. So we use a male product, and we recommend that women use about a third of what a man would use. And the recommendation with current guidelines is they should have a blood test before they start treatment, just in case they've got a reasonably high testosterone level already and treatment would be inappropriate. And then again, it's sort of 6 to 12 weeks to make sure that their levels are not too high. So that should be the patient's expectation.
Okay, so you've beautifully answered my next question about testosterone and what the risks are. So thank you very much for that. And my last question before we move on to listeners' questions is, how long is it safe to stay on HRT? And I guess, again, this is an individual, but, ballpark figures, what general advice do you have about that?
That depends on the patient, and it depends on the patient's circumstances. There is no mandatory stopping point, so you don't have to come off HRT after 5 years. And I think that was a really entrenched myth. The recommendation is for women as they get older to use lower doses. That's not really happening just now. So I would say if you're on 2 milligrams as a tablet, when you get to 60, actually reduce it to 1 milligram or go transdermal and use a lower dose. That's much safer, and obviously ongoing risk assessments for things like blood pressure and also things like smoking and alcohol and all of those things that could impact on ongoing risk. For most women, I think it's important to continue with HRT whilst they're working, because it does usually help mean that they are hormonally stable. So work might be very challenging, and it might be difficult, and people might find it stressful, and they might get anxiety, but at least you would know that there was no influence of hormones in that. So I would say that definitely the message should not be that you need to take HRT forever. That's a choice.
Yeah. And nor is it the message that you can only have it for.
So there's two extremes, isn't there?
A very short
period.
It is
just about a common sense approach to how you
and individualized care. Okay, so thank you for those clear and detailed answers to my questions. As you know, I ask listeners beforehand if they can submit questions to be asked during the interview. Are you happy for me to ask you a few questions from our listeners? Well, quite a few questions from our listeners. Okay. So I must stress at this point that it's very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. So, the first question we have is, what is the long-term impact of a surgical menopause?
Surgical menopause is removal of the ovaries, and it's much more extreme. So you would go from one day having functioning ovaries if you were premenopausal, to not having your ovarian hormones. And even actually in postmenopausal women who might have been managing reasonably well, if you take their ovaries out, they also lose the source of most of the testosterone, because their ovaries would still have been producing some. So it is just a much more extreme form of menopause. And sometimes the uterus will be taken out as well, which means that in most women, they don't need the progestogen part. So actually it's relatively easy in those women to give estrogen on its own, and estrogen on its own has less impact on things like breast cancer. So that's useful to know, I think. But the other thing is sometimes it can be difficult to control symptoms in women who have had a surgical menopause. So like I said before, if you get to the top licensed dose of something through your skin, a patch, a gel, a spray, and you still feel terrible, and you've added in testosterone because you've lost most of your source of testosterone, and you've had your bloods checked, and you've got a low sex drive, then we sometimes use implants. So we have quite an active implant clinic, and that's, I think, worth women knowing about. They're little pellets that get put in under the skin, and they last for 6 months, and they usually make symptomatic women feel much better. That's the good side. But the downside to implants is that when it's getting towards 6 months, when they're due to be replaced, women often feel very symptomatic again. But if you do the bloods, their bloods are normal. So it's quite difficult to manage that group of patients. And we have to just be careful about not doing the implants too frequently, because then women can develop really high levels. Once your estradiol level is more than 800, then that can sort of recreate symptoms of menopause. And that's the other thing about using excessively high doses of whatever you've been provided. That will create the same syndrome. It's called tachyphylaxis. It's just a big word, but it means that women feel symptomatic despite high levels.
Okay. Next question. Do you think women should just get on with the menopause? Are we making too much of a fuss?
So I think that,
I guess that depends on the woman.
That's an extreme statement, isn't it? It's a bit like everyone should have HRT. It's the opposite end of a normal spectrum. So I think women should have the right information up front on which to make the right decision for them. They should have the opportunity for a midlife MOT. And if they decide they want to have HRT, they need to be told about the options. So we've talked about estrogen, progestogens, testosterone, and then there is also a tablet called Tibolone or Livial, where it's a very specific type of preparation with estrogenic, progestogenic, and androgenic features. It's low dose, and it's recommended for women who haven't had a period for 12 months. But it's a good preparation. It doesn't increase the risk of blood clots, which is the commonest complication associated with HRT. And it will tend to manage symptoms without creating bleeding problems, much less likely than in women on estrogen and progestogen.
Okay. And you've kind of answered this already at the next question. What do you think of clonidine in those who may not be able to take HRT? You're not the biggest clonidine fan.
No, I'm not the biggest clonidine fan, and it would probably be my end of the road choice. So I have used it in women that nothing else worked for. So these new drugs that are coming to market, the neuroendocrine antagonist drugs, they are really exciting because we haven't really had a good licensed treatment. So for women who are listening, they're not available at the moment. We are currently doing a clinical trial for one of them called Oasis 3, and then the next study is called Oasis 4. That's the one in the breast cancer patients.
Yeah, that sounds really, really exciting.
Yeah, it's really exciting, and it's been a really good opportunity to collaborate with the breast surgeons. So we're working together to recruit, and that's how I think things should be. So again, I think if somebody's got breast cancer or had breast cancer, and whoever you see doesn't speak to your breast surgeon, I wouldn't take the advice they're giving you. The same with gynecological cancers. I think it's really important, and even if you think you know the answer as a clinician, you should doubt yourself. And I think we should, that's an important part of medical training, isn't it? To ask yourself, is this the right thing for this patient? And to check with somebody else is not a weakness, it's a strength.
Yes, absolutely. Yeah. Okay. Next question. Why have we switched from being so worried about HRT to it now being all okay or portrayed as all okay? And again, you touched on this.
Undoubtedly the influence of the celebrities, and I think they've made a big difference. That's been great, but I think they aren't doctors, and they aren't, or nurses, and they aren't seeing the other side of the coin, and they don't necessarily have the same knowledge base as a clinician would. So I don't think that's right. I'm not comfortable with it, and I said that before. And the last documentary that Davina McCall did, and their documentaries are really good, but the suggestion that if you had HRT it would prevent dementia is not based on any sound clinical evidence. There is ongoing research, but we don't know the answer to that question. All we can say is that HRT doesn't increase the risk of dementia. So I've got a strong family history of dementia, and I wouldn't take HRT to alter my risk. It's not going to change my risk. I have to accept that, I think, anyway. So I think people get frightened about things like that because they're unpleasant medical conditions, but I don't think it's right if people are misled to think that if they do this, they'll not get that.
And conversely, you may not decrease your risk of dementia, but you're certainly increasing your risks of other things that, you may not.
If you're on oral treatment, and potentially, I suppose, breast cancer.
Yeah, absolutely. Yeah. Okay. Next question. Do you think we have adequate services for women with the menopause? If not, what would be your recommendations? So, chair of the British Menopause Society.
I've got great hopes that the Women's Health Strategy will improve what's delivered in a primary care setting. As I said at the beginning, general practice is very mixed. There are some exceptionally good women's health GPs, but I think most menopause should just be part of normal general practice, because what happens when you pick something out is then it's who's going to pay for that. But it is a normal part of caring from cradle to grave. So I think for the non-complex patients, they should be dealt with in primary care with the appropriate training and support. And that's what's been difficult. So what happened was we had the celebrity input, massive increase in publicity, but we didn't have a chance to have the infrastructure in place to make sure that there was the right training available. And we've kind of adapted what training materials we have so that some of the training can be done online, which obviously puts an onus on the person doing the training, and it loses that kind of mentorship aspect. But it's the best we can do at the moment. And then I think what potentially might happen, and it will depend on the area, is that you might see intermediate care. So that would be done by GPs who've had extended training. They might do ultrasound, they might do biopsying, and they would definitely fit things like Mirena to protect the lining of the woman, to provide contraception and to manage bleeding. And they might do a whole range of other things, but those won't be the majority of service provision. That will still be in general practice. That's how I would see it. And I think at the moment the gap is just widening. So there's nowhere for women to go, and they're inevitably going into private practices and paying a lot of money for something that I think they should be able to get on the NHS. And I do some private work. I'm not totally anti-private work, but I'd rather deliver menopause on an NHS setting because that's where it should be.
Yeah, and there's greater scope for multidisciplinary working, like you mentioned before.
That's what I think is lost when you work in a relative isolation.
Yeah, absolutely. Okay. So the next, I'm going to group two questions together because they are about breast cancer and HRT. What options of HRT are available, if any, if you've had breast cancer? And the listener says he or she is asking for a friend of mine. And again, you touched on that before.
Yeah. So that depends on so many things. It depends on the hormone status of the breast cancer, when the breast cancer was. And, as I said before, we work quite closely with the breast teams, and they don't always say no to HRT. But, the amount of work they invest in trying to get women healthy again, I think it just doesn't feel right that they would, all that could potentially be lost by jeopardized by being given HRT. The vaginal estrogen is completely different. So I think I wouldn't like to make any specific recommendations without much more in-depth knowledge. If it was somebody 20 years after a low-grade cancer, that's different. But again, you would like to think somebody thought really carefully about it. And a lot of women who've had breast cancer really don't want HRT, but the counter to that is some women who've had breast cancer are very symptomatic, and they may be really struggling and they may feel really low. So it's an option.
Yeah. And as you mentioned before, there are other
Yeah.
options apart from HRT
Yeah.
that they can use. Okay. Another question about breast cancer. I have a family history of breast cancer, a first-degree relative, but the listener is BRCA negative. Can she have HRT?
So she can have HRT. She may have a slightly increased risk because of her family history, but it doesn't mean she's going to get breast cancer. And if she has HRT and she gets breast cancer, then the likelihood was she would have got it anyway. So, I wouldn't say absolutely no to that patient at all. I think if there, one first degree relative is quite a common scenario. If it was lots of relatives, then there are family history units which are separate to the genetic units, and they can be really helpful. And actually, the one that we have locally, they now have a menopause specialist in there who did some training with me, so that's really good. But yeah, no, absolutely, that's a much more there's much more likelihood that person could have HRT.
Okay. And previous to this, I did an episode with Mr. Lester Barr on breast cancer, and he spoke about those family history clinics, etc. So I can guide listeners to that episode if they want to know more about breast cancer. Okay, the next question is an interesting one. Do men have a menopause?
Not in the same way as women. I think men can become testosterone deficient, and that can be associated with fatigue, low mood. They quite often develop abdominal obesity. So it's important that men would access the right sort of support. Some menopause specialists do manage male hormonal problems. You're much better, I think, with an endocrinologist for that. And it's important when you have a testosterone level for it to be done in the morning, because the levels change throughout the day. So it could be difficult to interpret the blood test if it wasn't done at the right time. And there are treatments for men. So I think it depends how symptomatic the man is, but it's not the same as a female menopause, because, female ovaries are pre-programmed to last 50 years, whereas testicles don't have that. Men can produce children for forever, really.
Yep, indeed. And again, we come back to testosterone. What is the advice on testosterone? Should this be taken also?
So just going back to what I said, I think it depends on the symptoms. If low libido is an issue, we have to remember that it's complex. I have just some, really interesting anecdotal tales. I had a lady who was on testosterone. She came back and I asked her if she was feeling better, and she went, much, much better. And I always think, oh, great, I'm doing a great job. And she went, but I'm not using testosterone anymore. I got rid of my partner. So I think that's just an example of, it is complex. And I think the thing about testosterone, there's no harm as long as somebody's had their bloods checked, they've got the right presenting complaint, they can have a trial of testosterone. But if the patient gets to 6 months on an appropriate dose for women and has had no improvement, there is no point in carrying on. It's not making a difference for them.
Okay, so a 6-month trial, and you think, broadly speaking, testosterone taken as prescribed in the prescribed dose is safe?
So we use Tostran, which is a product licensed for men. It comes from our hospital pharmacy, because GPs are not obliged to prescribe outside of license. So we do the prescribing. And the patient has 1 pump Monday, Wednesday, and Friday, and each pump contains 10 milligrams. So that gives them about 50 milligrams over 10 days. And I usually suggest women put it on the front of their thigh, because it can cause hairiness at the site of application. They don't grow a beard, but they can get quite hairy, some women, and they can wax it off from that site relatively easily.
Right, because that I'm finding is quite a common question and a common request from patients about low libido and the menopause and the use of testosterone. So that's really, really clear advice. Thank you very much. So our next question is, I have a question about HRT. I'm perimenopausal. I've just had a hysterectomy. I'm on estrogen and testosterone. Is a low dose of progesterone advised to balance all 3 main hormones, or not needed at all?
So it depends why.
And I guess we have to take into consideration.
Depends why she had the hysterectomy. If it was for endometriosis or they left behind the cervix, that's different. But if If it was for fibroids or some other premenstrual dysphoric disorder or something like that, then no, and it's much safer just to have estrogen. Estrogen on its own has less impact on breast cancer risk. So there's nothing to balance out. That's not something that we would need to worry about.
Okay. That's brilliant. So I guess we can infer from that question that she is on estrogen and testosterone. So I guess we can infer from that that there's no indication for progesterone in her case, and therefore there's no need to have it, because again, it just increases risk without any benefit really. Okay. So our next question is, I have a strong family history of dementia in my dad and aunt. I am 51 with no menopausal symptoms, apart from my periods have stopped. What is the evidence for taking HRT to reduce my risk of dementia? I wouldn't take it for any other reason.
We haven't got that evidence. I mean, we might have in the future, but right now we don't have that evidence. So I think, that's obviously somebody who's managing well, apart from her anxiety about the dementia. And I appreciate that, but I think we could start her on HRT and she might have horrible bleeding, and actually there's no evidence that it's going to make a difference to dementia risk. I think the other thing which I've seen a lot of media publicity given to is suicide. And I have to say, 30 years I've been doing this, and people do become suicidal, but it's not something I would automatically associate with menopause. I think, people worry about that, that if they don't have HRT, that their life will go upside down, and, they'll become very depressed and they might feel suicidal. For most women, that does not happen.
Yeah, okay. And our last question from our listeners. Why are GPs not trained up regarding HRT as standard, or are very reluctant to discuss HRT? It took me 6 years of struggling and was given different antidepressants. When I saw the Davina program, I went back and asked about HRT and still had a battle, but results have been life-changing. My symptoms started age 42. So there are a few things to unpick with that question.
There are, and I'm really pleased that lady is feeling better now. But the thing is, with the Women's Health Initiative study in 2002, basically everything went completely dead. There was no education, no research. Basically, everyone came off their HRT, and so that created a great big gap. And younger doctors now obviously are able to have training, but there was the group in the middle that missed out, and it's really, really difficult to recover from something like that. And it's really difficult to recover from any misinformation. So as I said before, we're going through another phase where there is other misinformation out there. There are really, really good resources available. And as long as we try to address the trainer bottleneck, I think that we are going to see an improvement. And, I really feel sorry for that particular patient, because she shouldn't necessarily have had to suffer for a long time. But like I said at the very start, early menopause is the most difficult to manage, because you're stuck with normal blood tests but a symptomatic patient. And being on just even a normal combined pill would mask menopausal symptoms in somebody who doesn't have a contraindication. So up until the age of 50, she could have been on a combined pill if she was eligible, and then transferred to HRT.
And that's the other thing about these questions, is we don't know the total circumstances about this patient. What was her body mass index? Is she well otherwise? There may have been legitimate, I think reasons.
One of the other myths is women are taken off the combined pill in their 40s, told it's high risk, but actually there are lots of benefits, and that's another myth. And myths come from all over the place. They might come from, I don't know, secondary care gynecology as well. So it's not, it's not just GPs. It's I think we all need to access the right information. And the International Menopause Society have a training program which is online already, so anybody can get good quality peer-reviewed education.
That's fantastic, great. And again, I'll if you can forward a link for that, then I can, pin that to the podcast, because I know there are a lot of doctors and healthcare workers who also look at the podcast. So, it would be really great to have to be signposted to appropriate resources. So, my last question is from me. And it is that in your career, you have managed over the past 30 years, many, many women who are menopausal. Given the opportunity, is there anything you'd like to say to patients who think that they may need assistance with the menopause?
Yeah, so I would say get the right information, and as a patient that is really difficult to know where to go. So the British Menopause Society, Women's Health Concern, which is our patient facing arms, are reputable sources of information. NHS England have a Think Menopause campaign, and they've done a patient information sheet which is just 2 sides, so really, really easy to access. It was peer reviewed by a multidisciplinary team. So I would recommend that as a really reliable resource. And once you've got the right information, I think it's easier to go to the doctor and say, these are my symptoms and this is what I think would help, and have a conversation about it. There's also part of the NICE guideline, which is for patients specifically. You couldn't get any better information than NICE, and the NICE guideline is being reviewed currently, and that will be published in 2023. So we all, have to wait and see what's in there. But the current guideline is very good and very supportive, and it has made a big difference to women.
Great, thank you very much. Okay, so in closing, Paula, thank you very much for coming on to the podcast today. Thank you for supporting my efforts to educate patients, families, etc. But most of all, thank you so much for the many, many years that you have spent helping women through the difficult time that the menopause can pose. Thank you so much.
Thank you very much. It's been lovely.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.